Vincent is from MSF. He's also a consultant in critical care of WHO, but also as an intensive care training advisor for MSF. So he's been serving in MSF for more than 10 years. So today he's going to give us the perspective from MSF in terms of the NGO's journey to training healthcare workers in emergency and critical care medicine. So thank you, Vincent.
Hi, good evening all, and thank you, Kevin, for the welcome and the introduction, and thank you also to Colin for inviting me to this symposium. I remember the first pilot course we did together in IT in 2013. Hi, Colin, and the second pilot course was with Kate in Pakistan in 2013 as well. So nice to see you all, guys, and I'll try to discuss with you our approach at MSF of emergency and critical care medicine training, which is a difficult question because actually we are not a university body. We are just an NGO, that provides free medical care in settings where the health system is overburdened by a crisis or by a chronic malfunction of the system or lack of resources. And here is to give you an idea of what we are actually doing at MSF throughout MSF sections. That's the feature for 2020 activity, and it's about 1 million emergency room admission and 800,000 patients admitted in hospital, which represents, gives you an idea of the acuity that is of illness that is met in MSF facilities, where we actually have to face very, very different settings. Just to give you a few examples, here we are in Jaun in Nigeria. It's an obstetric facility. The number you can see is the hemoglobin rate of the patient, 0.6. So you can see that we are facing sometimes the extreme of human physiology. And here, in this situation, only obstetric patients. Here in Aden, in Yemen, we have a trauma center where we deal with only trauma patients. And with the COVID crisis, we've been challenged and actually pushed towards increasing the intensity of care and the level of care we usually provide in MSF project to respond to the ongoing COVID pandemic. So to summarize, we have actually when we speak about MSF field hospitals, it actually encompasses very different realities. We have the project lifespan, which is very different. It may be few months for an Ebola outbreak, for example, or for a natural disaster, up to few years when we deal with HIV/TB inpatient departments, or health systems which are chronically low-resourced and in difficulties, such as in Central African Republic or in Sierra Leone. We also have actually the total number of staff working for MSF is 38,000. That includes the administrative, logisticians, and all types of staff. We have a great majority of national staff and few international staff. The projects are different sometimes as well, because sometimes they are run as MSF standalone projects. In other situations, and this is more and more the case, it is a collaboration with an MOH facility. And so MSF workers are embedded or are being, or the local staff is being incentivized by MSF. So this is really a very different settings, because the questions of how much we control the overall chain of care. I mean the care pathway, and how sustainable what we are working on is very different according to these settings. We also have, as evidence just before, we have a situation where we run a field hospital where any kind of patient can present to the hospital, whether an adult, whether a child, whether pregnant, whether having a medical problem, a surgical problem. So, and that was for example, the basic DHS course is aiming at covering is a mixed population of patients. But more and more, we have to deal with projects that run only specialized activity. And I was mentioning before obstetrics, but it can be also HIV TB wards, who present a lot of patients with high acuity, who actually would be in ICUs in well-resourced settings, burns, or trauma. And finally, and that matters for when you consider the training you're gonna deliver. The countries where we operate are a very variable healthcare system. The educational pathways are also very different. In some places, emergency and critical care medicine are recognized specialty. In other places, and that's the most frequent, it is not. And we have a lot of language challenges, especially when we teach nurses. So I would like just to go through the way we have actually tried to improve the how we deliver training in our facilities for the last 10-15 years. The baseline is actually at MSF that we have a very strong we are working very strongly on the protocols, and these protocols are contextualized, and this is the actual result of the experience of the clinician in the field. So the protocols are really the backbone of the quality of care we try to achieve in the field. Obviously, as it is in well-resourced settings, you have senior clinicians, junior clinicians, and there is a transfer of skills and knowledge which is non-standardized, but which do occur in the routine of healthcare practice. We've tried to introduce short courses which were of two types. Either they were homemade, that means that we have training units, we have learning designers, and some trainings are specifically designed for a specific context, which is and the course are often delivered on site. We've also tried to introduce branded courses such as basic DHS, now called LR for low resource settings, such as advanced life support in obstetrics, such as the primary trauma care course, or Help Baby Breathe courses. So these courses are very interesting for us because it helps in standardizing the way we train, the way we teach. The difficulty is that often we started with providing those courses off-site. That means in the regional capital of a country or in the capital city of the country, in order to ease the organizational work for organizing the course, to materialize trainers, trainees. In MSF, we have a very complex way of working. That means that we have 5 operational centers, which have different ways of working. So we attempted actually to have a unified approach of how we train. But the difficulty was that we were actually out of the facility and we have rapidly shifted to other models. Just to mention and to echo the talk of Kate about the way we've worked with the basic collaboration and how it has benefited to both sides. It's actually a very informal collaboration. We've never signed, and the people in MSF are always asking for a memorandum of understanding between the Chinese University of Hong Kong and MSF, and we actually, Charles was very strongly against it, because actually that's when you do MOU that the thing starts not working, and it has been actually well working, I think, for the last 10 years, because both sides had benefits in the collaboration. So for us, I think what is really great by collaborating with the Hong Kong team is to benefit from the high experience in the educational engineering, whether it is the style of teaching, whether it is the illustrations and the wonderful work done by Janet Fong, whether it is the digital support for the learning management system, we are running 4 apps for trainees and for trainers. So that's really a wonderful support. This also gives some credibility to the course we run, for the training we run, because there is an external review, and the staff in the places where we operate are very fond of having courses that have a kind of international accreditation. So that's really an important point and it's a strong incentive for the staff. For the basic collaboration, and I may miss some points, but the main point that I think MSF brought to the basic collaboration is to allow an adequate course contextualization. That means we have an understanding by the variety of the field where we work on how to not to best manage. That would be very arrogant, but how to manage a patient when you lack resources. And I think the question of how much fluid we have to give a patient, as mentioned by Giles, is really very relevant to this course, and that's very important questions, and we address them specifically in the course by especially advocating for a lower volume of fluid bolus when you give it. And also what Charles Gomerson mentioned is that having the brand of MSF for the course was useful in branding the course in other facilities in low and middle income countries. So coming back to our the way we try to actually improve how we deliver training. And I'm not restricting myself to the basic course, because as you've seen, there is we are running other courses. We have a course on triage. We have a course on mass casualty incident. We have POCUS courses. There are courses which are specific to different types of projects. But we've really shifted our approach to, and here it is specific also to the basic course, to on-site courses, because actually we teach. That means that we teach to less people. That means we need to run more sessions. That means more organizational issues. But what we are trying to achieve is to train all the health workers of a given health facilities, so that everybody at the same time receives the same amount of information. And this led us very quickly to, as Kate mentioned, to actually design with the Hong Kong team a course for nurses. And we always, the assumption is that when you run basic course, you run the course for nurses and the course for doctors. And the assumption also that we made, which is debatable, which has the advantage and disadvantages, is that nurses and doctors do not learn the same way, and so that they need to have a specific teaching approaches. This gives actually the opportunity to perform before when we receive a course request for a course, to perform a structured need assessment. And it leads us to the questions discussed by Kate on actually understanding what is happening in the field, understanding what is available, what is not. And what is also very interesting to understand is why actually the facility is requesting for a course, or for why do the managers, the supervisors think that a course is needed. And very often you may find out that finally the course may not be the appropriate answer to the problem they have, and that you should consider another intervention, such as actually putting in place a triage system, or putting in place an early warning system to detect clinical deterioration in the ward, or increasing the staff, increasing the number of human resources, or some equipments are not available. So performing a structured need assessment allows to understand exactly what is the need behind, and whether the course is the good answer, whether it is the good course, and what type of other interventions are needed in the same time. The other point that we try to address is to increase the educational efficacy of the courses, and that has to be balanced with how you want to disseminate the course and how you can train the trainers. The example is the typical example is a simulation exercise, which are actually quite challenging to run if you want to run them safely. So we've been trying to introduce them in the course, but we are actually we face a lot of challenges. You may end by doing the wrong things, or doing them with the wrong methodology. And fortunately now in MSF we are helped by the support of an MSF simulation lab, which helps us in actually training the facilitators and following an appropriate methodology, especially for briefing and debriefing. The other aspect of how we try to improve the way we train is to improve the contextualization of the learning activities. To give an example, we've been in 2018. We were several HIV/TB wards asked us to run the basic course. In those wards, sometimes the acuity of the patients is really high. You have a patient with acute renal failure with 4 grams of hemoglobin and disseminated TB. It's a quite of hell for an intensivist to understand how much fluid I should give, and everyday questions about diagnosis and management. And obviously for this type of context, the content of the course on trauma and burns is completely irrelevant, and you need in the other direction to design other course activities which consider, for example, acute respiratory failure in an HIV patient, or altered mental status in a severely immunodepressed HIV patient, and that's not covered in the present version of the course. So contextualization is a very big challenge, and right now we are working on contextualizing the basic LR course for obstetric settings. And believe me, we have a lot of things to change, either to actually remove from the course or to add. The security issues and the COVID-19 pandemic gave us actually the opportunity to work on digital tools and to develop blended approach with a combination of e-learning, virtual class, or skill stations run remotely. I think the basic collaboration has this experience as well with the generic basic course. And we have to rely more and more, and actually we found it more efficient on the facility-based trainers. That means national or international staff who are actually working in the project and who are mentored, sometimes through video conferencing, to deliver course activities. And actually, it gives a lot of power to what we try to achieve, because it ensures a follow-up, and it ensures that actually the course principles are actually being used, and that there is some supplemental clinical supervision after the course is run. It also sometimes allows to run the course, to deliver the course in modules instead of having a 3-day model. That sometimes suits better the routine of the activity, which does not allow to remove for 3 days healthcare worker from their routine. Giles mentioned earlier free open access medical education. That's a frequent request we get. Please give the course material without organizing, without the pain of organizing a formal course. And the problem is again that with this type of giving access to the material, we don't give a chance for interaction or mentoring to occur. Very frequently, actually the trainees are left with the material, but with no time, no protected time being organized in the facility to allow them for going through the material, and also no follow-up, no documentation. So we really need to go beyond that. And in addition, as mentioned by Giles, the problem of contextualization is also of the appropriate contextualization, appropriateness of the content. That's so a big challenge. And so finally, we get to what we would like to improve, and what we actually are trying to achieve in the recent version of the course is how to organize structured clinical supervision along with the course activities. Trying to implement logbooks that are actually targeted to the course contents. It's not easy. It's also articulating the presence of a person who can run the course, because the person who can run the course is usually somebody who has to have some clinical experience, who have to get some. We need to be keen to teach, who actually has also no language obstacles, and that's frequent for international staff that there is some language barriers, and the national staff are much better actually to deliver the course. And how we structured and standardize this clinical supervision is a question and a challenge. But we really look actually for trainers who actually can either are already in the field or are going to stay for a significant time, 1 month, 2 months, 3 months in the field, to actually give some clinical supervision to actually complement the transfer of knowledge and skills. And the other thing is that we are all the same. We don't have time to read a long protocol, and we really are working on how we translate we ease the implementation of course principle by job aids, and that's another area area of opportunity. Actually, is actually how we articulate training and the use of job aids, and as earlier mentioned, how we articulate clinical supervision and learning activities. And what the opportunity of developing these models of going beyond the short courses is the flexibility, because when you rely on the staff who is already present in the health facility, you have much more flexibility to organize and to start quickly the training. The challenges are those of how we protect training time in those facilities, how we ensure that the good person is at the good, is present when we need the training, and it's sometimes difficult to identify. We have sometimes a bunch of very junior staff with few who are actually keen to and who have the clinical experience which allows them to actually run a course. We have the problem of monitoring and documentation of training activities, and also of availability of the training equipments, even if we try to be as low tech as possible. We have some tools. This is actually the e-learning platform of MSF, which is called Tembo, where we all learning activities are being displayed. A lot of them are related to acute care, but it may also relate to other areas where MSF is working, and for example, logistician may find also on this platform a course for them. So it's really something which is institutional. We are lucky also to have an MSF field simulation lab, and now we always try to run, when we run a course, a simulation exercise, we try to get their methodological support, and they have also some e-learning facilitation courses for simulation, and so we encourage our trainer to go through those courses, we follow their methodology, and we now try to run whenever possible, after nurses and doctors course, an interprofessional simulation exercise, which is always a very big challenge in terms of our organization, but that's something we try to do. Just to give an example that these approaches are actually feasible, that's the example of the courses we ran in Lashkargah, in Boost Hospital in Lashkargah in Afghanistan last year. Actually, we had no possibility to send external trainers, and we actually mentored we give an orientation to the use of the course material on WhatsApp and video calls to national staff, and they actually have run 3 sessions in 2021, and we never sent anybody there. So that's I think, and now we are considering using them to run other courses in Afghanistan. So as earlier mentioned by either Giles or Kate, that's really relying on local resources is really a factor of sustainability of the training process. The example we would like to follow, I mean, as an institution, is actually the way the POCUS training program is run at MSF. It's actually 4 to 6 weeks training session, where an external trainer is sent in the field, and beyond theoretical knowledge and hands-on, the trainer supervises all the scans that are required to complete for getting the course certificate, and the trainer is embedded in the project, so for a period of 4 to 6 weeks, and then afterwards a course focal point is designed in the facility, and support via telemedicine is given to the trainees while they are using POCUS approach, and whenever they have a difficult case or a question. Thank you very much, and I am ready for questions.
Thank you very much, Vincent. Great talk, and always amazed by the high standard of care delivered by the MSF team in the very difficult situation. I see Colin is here joining us.
Just to
Maybe he
say
can also
bonjour,
share his
Vincent.
thoughts.
Thank you very much. That was fabulous. And just like Kevin, I'm always humbled and stunned by what you and your organization do. It's just amazing. It really is. And it's wonderful to see how the courses, both the ones in the Hong Kong context and more generally, have continued to make such great strides over the last decade. Amazing.
I think we are really challenged by the and we learn a lot as we, and I think that's what's really is very efficient with the basic collaboration is that we are not fixed in a course model that we cannot change. And that's really this feedback loop on how we on taking lessons from the difficulties we have. And I think the interaction with Kate is also very useful because we face different challenges for many reasons, and being able to feedback and to have a quick adaptation and improvement of the course is really something we did not find with some organization, where you have to run the course the way it has to be run, and you should not move any commas from the standardized material. So that's really has been something very powerful in this ongoing collaboration.
I would fully support that. I mean, the need to adapt and change in response to what you find on the ground and the needs of the learners is just so critical. And that, as you said, that will change so much from a place like Afghanistan to Africa to Asia. It's going to be hugely different depending on where you are.
So I think Kate has a question, but I think, Kate, you can turn on your camera and your mic, and we can have a discussion. I think.
Okay. Hello, Vincent. Nice to see you. Yeah, I wondered if you could share a little bit about. I know recently you've taken on this WHO role, and maybe you're involved with their emergency care training. So I just wondered whether you could share a little bit about your experience with that.
Yeah, Lee is sharing on Monday, but I think Vincent can give his first version. I think that's a good idea.
Yeah, so Lee is my boss, so I'll try. You will be able to check with him on Monday. Then, no, I think the scope of the basic emergency care course of WHO and the basic LR training are similar, even if actually the basic emergency care course is addressing the immediate management of the acutely ill patient, when the basic course is also considering the ongoing management and the prevention of organ failure. And that's really a very strong point, is how to avoid organ failure, how to detect early clinical deterioration. So I mean, the basic emergency care course is really great, and it's a wonderful educational tool, and I think it's being spread in a lot of countries, and it's really very useful. I think so. They are slightly different in the scope, and now actually what I am working on with a colleague from Ghana, Giles, is so it's Dr. Christian Ou. So we are both critical care consultant working for WHO and working on the development of a critical care course for WHO. The challenge is to define the objectives, and the defining objectives for many different types of setting is really challenging. But I think WHO is strongly convinced that the amount of critical illness in low and middle income countries is really huge, and we need to. It's an urgency actually to address this invisible patients, because they are not in ICUs, because they should be in ICUs, but they are in wards or they are in emergency departments, and we don't see them. They are not identified as critically ill, but very simple intervention can save a lot of lives. So I think the need, as demonstrated by Giles earlier, is actually there.
Yes, absolutely agree. I think when I was there in Tanzania, we always hear doctors say that patients come too late. I think and I think when we have the critical care mindset or intensive care mindset, I think often simple things can be done to save these patients, and I think these work that all of you are doing are great, and I think that's a great sharing for our audience here today.